Right now, I want you to do something that takes 3 seconds. Press both palms tightly over your ears, flat against them. Now listen. Do you hear a high-pitched tone? A hiss? A low hum? A cricket chirping that never quite stops? You have probably told yourself that sound is nothing. Old ears, normal aging, too many rock concerts 50 years ago. You have been misreading that sound your entire life. Because that ringing, that phantom noise that only you can hear is not primarily an ear problem. It is a body-wide communication system. And when it starts, when it changes, when it becomes constant, your body is telling you about three things at once: your blood flow, your nerve health, and your muscle tension patterns. Ignore it, and you risk missing a small blood vessel abnormality that could grow, a nerve inflammation that could become permanent by next year, or a medication side effect that is quietly damaging your kidneys and your inner ear simultaneously. I am Dr. Alex Carter. I have spent 23 years as a clinical audiologist and neurodiagnostic clinician. And here is my question for you right now before we go any further. When did you first realize the ringing was not going away? Was it during a quiet night last winter? After a stressful week? Or has it been so long you cannot remember a time of true silence? Tell me in the comments. Just say last winter or years ago, or I honestly don't remember silence. I read every single one, and I need you to stay with me through sign number 5. That is the one I have saved deliberately for the end. The one that can be completely reversed if you act now, but permanent if you wait another 6 months. But first, you need to understand what is actually happening inside your head, because you have been told the ringing is in your ears. That is not quite right. The ringing is in your brain's interpretation of silence. Think of your auditory system like the geological record of a canyon. Every sound you have ever heard left a tiny trace, a layer of sediment. The brain is constantly comparing what it expects to hear with what it actually hears from your ears. When that input drops even slightly, the brain does not go silent. It generates its own sound to fill the gap. That is the ringing, a phantom sound your own brain creates because it is desperate for real input. Now here is what your doctor is not failing to do. Most primary care physicians are given 7 to 12 minutes. Tinnitus is not part of the standard screening protocol unless you mention it first. That is not negligence. That is a system built for acute problems, not subtle chronic signals. So your job is not to blame them. Your job is to become the kind of patient who brings them the right information. And the decade that makes this urgent for you? Age 65. That is the average age when what was a minor occasional ringing becomes a permanent daily companion. But the window to intervene begins at 58 and closes by 72. You are right in that window. So let us walk through 5 signs your ears are sending you. Not symptoms you need to panic about, signals you need to translate. Sign number 1, pulse synchronous ringing. The medical term is pulsatile tinnitus, and in plain English, it means your ringing has a rhythm that matches your heartbeat exactly. Here is precisely what to look for. Sit in a quiet room. Place your index finger on the side of your neck, just under your jaw, where you feel your pulse. Now listen to your ringing. Does it whoosh or thump or pulse at the exact same rate as your finger feels? Not faster, not random. Lockstep with your heart. Normal ringing is steady. A continuous tone, like a refrigerator hum. That is almost always neurological or metabolic. But pulse synchronous ringing is different. That means there is turbulence in a blood vessel near your middle ear or inner ear. And turbulence happens when a vessel is narrowed, twisted, or has an abnormal connection. Here is a patient story. Eleanor, 67, a retired legal secretary, noticed a whooshing sound in her left ear only when she lay down at night. She thought it was her pillow. Her husband told her it was probably sinus congestion. For 8 months, she did nothing. Then one morning, she turned her head quickly to back out of her driveway and heard the whoosh become a roar for 10 seconds. She saw her primary care doctor, who ordered a specialized type of MRI called an MRA, magnetic resonance angiography. They found a dural arteriovenous fistula. That is an abnormal connection between an artery and a vein inside the covering of her brain. It was treatable. They performed a minimally invasive procedure through a catheter in her groin. The whooshing stopped before she left the recovery room. If she had waited another year, that fistula could have bled. A brain hemorrhage that would have been catastrophic. Practical takeaway. Here is what you do today. Check your tinnitus against your pulse 3 times. Sitting, lying on your left side, lying on your right side. If you hear a match, write down which positions make it louder. Then this week, call your doctor and use these exact words. I have pulse synchronous tinnitus, and I need a referral for an MRA of the head and neck. Do not accept a standard MRI without contrast. You need the angiogram version. Sign number 2, ringing that changes when you turn your head or clench your jaw. Look at what you are doing right now. Slowly turn your head as far to the left as is comfortable. Hold it there. Listen to your ringing. Now turn to the right. Now clench your molars together firmly. Did the pitch go up? Did it get louder or softer or shift from one ear to the other? Most people assume the ringing is happening deep in their inner ear, but your neck and your jaw share nerve pathways with your auditory system, specifically the trigeminal nerve and the cervical spine nerves. When the small muscles in your upper neck go into spasm, from posture, from screen use, from sleeping wrong, they send signals to your brain that overlap with hearing pathways. Your brain gets confused and turns up the phantom volume. Normal ringing does not change with movement. That ringing is coming from the cochlea itself. But ringing that responds to posture or clenching is coming from your neck or your jaw muscles. That is actually good news, because muscle and joint problems are highly treatable. Here is Margaret, 62, a retired florist who spent 40 years leaning over tables arranging bouquets. She had mild ringing for a decade, but at 62, it became a screech every time she looked down to read a recipe. Her ENT told her there was no hearing loss and sent her home. Her daughter, a physical therapist, noticed Margaret's left shoulder was 2 inches higher than her right. She took her to a cervical spine specialist. Imaging showed severe arthritis at the C1 to C2 junction. 3 months of specific physical therapy, no surgery, no drugs, reduced her ringing by 80%. If they had waited, the nerve irritation would have become permanent central sensitization. That means her brain would have locked in the ringing as a permanent pathway, even after fixing her neck. Practical takeaway. Today, perform the neck and jaw provocation test. Turn your head slowly in each direction. Clench and unclench. Open your jaw wide. Tilt your ear toward each shoulder. If any movement changes the ringing, you have found a musculoskeletal cause. This week, ask for a referral to a physical therapist who specializes in cervical spine and temporomandibular disorders. Not a general PT, someone who knows the C1 to C3 connection to the auditory nerve. Here is where I want you to pause. Comment prompt. In the comments right now, type the number that matches your ringing. Type 1 if it is constant and never changes. Type 2 if it pulses with your heart. Type 3 if it changes when you move your head or jaw. Type 4 if you have more than one type. I am tracking the patterns live. And if you are finding this information useful, you belong here. This channel is for adults over 60 who want the information that belongs with you, not behind a consultation you have to schedule weeks in advance. So if you have not subscribed, tap the button. You will get the next video on the 3 medication classes that cause silent kidney damage before your blood work ever changes. Subscribe reminder. Sign number 3. Ringing with a sensation of fullness but no infection. Put your finger in your ear canal, not deep, just at the opening. Does it feel like there is pressure pushing back? Like you just got off an airplane that never landed? That sensation of fullness, when paired with ringing, is a specific signal. Here is the important distinction. Fullness with an infection comes with pain, fever, or drainage. That is a middle ear problem. But fullness without any of those things, just a blocked sensation and ringing, points to one of 2 possibilities. First, Eustachian tube dysfunction, where the tube that equalizes pressure cannot open properly. Second, and more urgent, a condition called endolymphatic hydrops, which is too much fluid pressure inside the inner ear. That same pressure that causes ringing, if left unchecked, can damage the hair cells of the cochlea permanently. The science is simple. Your inner ear is filled with 2 fluids. One is high in potassium, one is high in sodium. They are not supposed to mix. When pressure builds, that barrier breaks down and the fluids mix. That chemical confusion sends chaotic signals to the brain. The brain translates that chaos as ringing and fullness. Here is a story. Robert, 70 exactly, a retired high school principal, had fullness in his right ear for 2 years. He assumed it was allergies. His ringing was a low thrum that his wife could not hear. He tried antihistamines. Nothing changed. At his annual physical, he mentioned it almost as an afterthought. His doctor ordered a test most physicians do not think of, a glycerol challenge. They gave him a liquid to drink that temporarily reduces inner ear pressure. His hearing improved by 20 decibels for 4 hours. That confirmed hydrops. He started a low-sodium diet and a mild diuretic. 8 weeks later, the fullness was gone and the ringing was a whisper. If he had waited another 18 months, the hydrops would have caused permanent scarring inside the cochlea. At that point, no treatment works. Practical takeaway. Today, test for fullness by pinching your nose and gently blowing. Do not pop your ears hard, just a gentle pressure equalization. If that changes the ringing or fullness, your eustachian tubes are involved. This week, document what makes the fullness worse: caffeine, salt, alcohol, or weather pressure changes. Within 30 days, ask your doctor for a test called electrocochleography, or ECOG for short. That measures inner ear fluid pressure directly. And use these exact words: I need to rule out endolymphatic hydrops before we call this normal aging. Sign number 4, ringing that changes pitch within 30 minutes after a meal. You have probably never connected what you eat to what you hear. But your inner ear is one of the most metabolically active tissues in your body. It demands a steady stream of glucose, electrolytes, and oxygen. Here is the distinction. Normal ringing is stable hour to hour, but ringing that rises in pitch after a high-sugar meal or that drops in pitch after a salty meal is telling you about your glucose and sodium regulation. Blood sugar spikes cause fluid shifts inside the inner ear. High sodium pulls water into the endolymph fluid, increasing pressure. Low potassium from not eating enough vegetables makes nerve signaling erratic. The science is straightforward. The hair cells in your cochlea convert mechanical sound waves into electrical signals using a process that depends on precise ratios of potassium, sodium, and calcium. When your blood sugar spikes, your body releases insulin, which temporarily lowers your serum potassium. That throws off the electrical gradient in your inner ear. Your brain hears that as a pitch change. Let me tell you about Diane, 64, a retired nurse practitioner. She noticed her ringing would start low, like a foghorn, after breakfast, but by mid-morning, it would climb to a high squeal. She thought she was imagining it. Her husband bought her a white noise machine. Then she went for a routine blood draw. Her A1C was 6.4 pre-diabetes. Her fasting glucose was fine, but her post-meal glucose was spiking to 180. She started a continuous glucose monitor for 2 weeks. Every time her glucose went over 140, her tinnitus pitch climbed. She changed her breakfast from oatmeal with honey to eggs and vegetables. Within 10 days, the post-meal pitch changes stopped. If she had not caught this, the glucose spikes would have damaged the small blood vessels in her stria vascularis, the part of the cochlea that maintains fluid chemistry. That damage is irreversible. Practical takeaway. Today, listen to your ringing immediately before a meal, then 30 minutes after. Do this for 3 different meals. 1 high in carbohydrates, 1 high in salt, 1 balanced. Keep a log. This week, ask your doctor for a test called a 2-hour postprandial glucose and a fasting insulin level, not just A1C. Within 30 days, request a complete metabolic panel that includes magnesium and potassium. Low magnesium is a hidden cause of nerve irritability in the auditory pathway. Sign number 5. And I promised you this is the most important. Ringing that is louder in one ear and comes in waves, loud for a few seconds, soft for a minute, then loud again. It is not constant. It is intermittent. This is the one most people dismiss because it is not always there, but that intermittency is precisely why it matters. Here is what you are looking for. Ringing that is clearly lateralized to one side. You can point to the ear, and that comes in episodes lasting 5 to 30 seconds, several times per day. Between episodes, you might have almost complete silence. Normal, constant tinnitus is usually systemic, but intermittent, one-sided ringing is the calling card of nerve irritability along the auditory nerve itself. And that nerve is wrapped in a fatty insulation called myelin. When that myelin gets thin, inflamed, or compressed, the nerve fires randomly. That random firing sounds like ringing that comes and goes. Here is the patient story you need to hear. Kenneth, 69, a retired carpenter who wore hearing protection inconsistently. He had intermittent right-sided ringing for 14 months. It would buzz for 10 seconds, vanish, then come back 15 minutes later. He told himself it was nothing because it went away. His daughter is a nurse. She insisted he see an otologist, not just an audiologist. They ordered a specific type of MRI called a Fiesta sequence that stands for fast imaging employing steady-state acquisition. It showed a small vascular loop pressing against his right auditory nerve. Not a tumor, not a stroke. Just a blood vessel that had shifted with age and was tapping his nerve. They performed a microvascular decompression, a 45-minute procedure through a small incision behind his ear. He woke up with no ringing. If he had waited another 2 years, the nerve would have developed demyelination, permanent scarring. At that point, even removing the compression would not stop the ringing. Kenneth's story is why I saved this for last. Because intermittent ringing is the most reversible form, but only if you catch it before the nerve is damaged. And most doctors will not order the correct MRI unless you ask. Practical takeaway. Today, start a log of your ringing episodes. Write down the time, duration in seconds, and which ear. If the pattern is intermittent and one-sided, you have your answer. This week, call your doctor and use these exact words. I have intermittent unilateral tinnitus, and I need a referral for a Fiesta or CISS sequence MRI of the internal auditory canal, with and without contrast. Do not accept a standard brain MRI. That misses small vascular loops. Now let me give you your unified action plan across 4 time horizons. Today, right after this video, go into your bathroom. Stand in natural light. Look in the mirror. Take your phone and record a 30-second video describing your ringing. Say out loud which ear, constant or pulse synchronous or intermittent, and what makes it better or worse. That video is your baseline. This week, write down 3 things. First, a list of every medication you take, including over-the-counter pain relievers, because aspirin and ibuprofen can cause tinnitus at your age. Second, your average daily sodium intake. Third, your sleep position, because sleeping on one side changes cervical spine tension. Within 30 days, request these specific tests by name. A complete blood count to check for anemia, because low red blood cells increase blood flow turbulence. A basic metabolic panel with calcium and magnesium. A vitamin B12 and folate level, because B12 deficiency causes nerve demyelination. And a thyroid panel, because hypothyroidism thickens inner ear fluids. At your appointment, use this exact language. I am not asking for a cure. I am asking for a rule out. I need to rule out a vascular loop, a cervical spine cause, a B12 deficiency, and endolymphatic hydrops before we conclude this is normal age-related tinnitus. And I need to say this clearly. These signs are prompts for a conversation with your doctor. They are not diagnoses. If you have sudden ringing that appeared overnight, or ringing with dizziness or weakness on one side, do not wait. That is a medical urgency. Now let me reframe everything you have just learned. Your body has been talking to you through that ringing, not as a punishment, not as a nuisance, as a loyal communicator that has been sending signals you were never taught to read. The pitch, the timing, the ear location, the rhythm, all of it is data, and you now know what to look for. Here is my final question for the comments, and I want you to be honest. What have you been quietly dismissing in your own body? Not just the ringing. The thing you have decided is probably nothing. The sensation you do not mention at family dinners. Tell me one thing. Use one word or one sentence. I will respond to as many as I can. If you know someone over 60 who has mentioned their ears ringing, send them this video. Not as a favor to me, as an act of care, because that person might have been told their whole life that nothing can be done. And now you know better. This is Dr. Alex Carter. The silence you have been missing is still possible, but you have to start the conversation.